start off with a good morning again, and I will be doing this lecture on recognition and prevention of deteriorating patient or deterioration in a patient, because I think it is a very timely lecture. Reason, we are running low in resources in our country, especially in the health sector, and if we pick up a patient early, if we do the needful to the patient early and get the patient better, we may not need high-flown management techniques in and intensive care for these patients. So we can actually save a lot of resources, a lot of money for the country, and also we may be able to prevent death in these patients. So let's move on. Now, why do we want to recognize a patient early? Because if we recognize them early, we can act upon it and save them before they go down this slippery slope. Now, what is this slippery slope? Now, start off is prevention. Now, prevention is where the patient has to do it, and sometimes the part of it is the patient should come to the hospital on time. Now, these days we have a lot of problems, isn't it? Fuel problem, and other problems where we can't come to the hospital on time. So most patients come very late. So if we are smart enough, can we recognize them early? Now that you all are skilled people, competent people, yes, we can recognize them early and we can give them a very aggressive management where they can go back on that slippery slope, not to fall down on the slippery slope. Okay? And sometimes they will need critical care if you don't do the timely interventions. Sometimes they may go into cardiac arrest and end up in an ICU or even death. So let's see how we are going to do this. Now, I said a lot of patients nowadays come very late. We can't stop that. So what shall we do? Shall we say that we can recognize the high-risk patients who are coming to the hospital and give them more attention? What are the patients who are high risk? The patients who are having coexisting conditions, all emergency admissions, elderly people. What is elderly? More than 65 years of age, right? And some people who have specific acute illnesses, and all of them can be having altered level of consciousness, and the trauma patients, the ones who come with polytrauma, you saw the last case scenario, how we managed it. So that kind of a management is important in all these patients very early. So how do we recognize these patients? Now, most of the time I hear when I go to the ICU, not mainly the ICU, but some areas in the hospital, they bring patients to the ICU and say, Madam, me khata kar kar hitiya me then arrest hona. It can happen very rarely if the patient ends up with a massive MI. But most of them, I don't believe it. 80-90% of patients, they tell you, we are deteriorating, we are arresting. But none of us are going to take any notice on those patients. That is the problem where the patients are in, right? So what do we have to do for that? How do they communicate? Are they tell you in words? No, they won't. They will tell you in 6 signs. And these 6 signs are the signs that anybody check on a patient. When a patient is admitted to the ward, the nurse checks respiratory rate? Don't they check the respiratory rate? Do they check the oxygen saturation? If there's a pulse oximeter, they would. Temperature, they invariably check systolic blood pressure or the diastolic pulse rate and the level of consciousness. They talk to the patient. If the patient is conscious, they record conscious, GCH 15 out of 15, isn't it? Right. Now, these are the signs they talk about to us when they are deteriorating. So now we can take these signs and make tools. What do you mean tools? Tools are there to pick up patients who are deteriorating. Now these are the tools that are there internationally to pick up patients. Modified early warning score. Then there's another score that is called MEOS, which is obstetric early warning score. Then there is PUS, which is the Pediatric Early Warning Score, and the NEWS, which is the National Early Warning Score. These scores have come up because the ranges are a little different in each group of patients. Now, a mother who is pregnant, heart rate is above 100, but a normal patient's heart rate 100 is abnormal, right? So, because of that, we have these different early warning scores. If you want to download, internet has all this information. You can go and download these scores. So this is modified early warning score, and this is news. A national early warning score. That this is MEOS, right? Okay. Obstetric early warning score. I didn't put the pediatric early warning score because this is an adult life support program with a deteriorating patient. Now, this is the chart that has in various institutions. Actually, there are a couple of institutions we have in Sri Lanka, private sector. They have this chart. I forgot to bring that chart, right? And this chart is the one that is going to help you to monitor these signs. Okay? And these signs can be monitored, and you can get a graph of all these signs in the patient. This is for the nurses, right? Now, let's see how we can use this early warning score. Now, can you see these 6 parameters are there? Central nervous system, respiratory system, heart rate, blood pressure, temperature, oxygen saturation, urine output. Okay? Now, if it is normal, within the normal range, the score is 0. Now, we are giving numbers to these ranges. Now, when the numbers are going up, the score increases. Agreed? Got it? Right. Now, when the scores are going down also, like respiratory rate going down, heart rate going down, blood pressure is going down, temperature is going down, again the scores are increasing. Okay? So now, this is a very good tool for you to pick up the patients, right? Now, if the score is 0, do you have a problem? No, they are ward patients. You don't have to worry, right? But if they get a score of 1, okay, be careful, right? So the nurse has to know to pick these patients up and inform us, the junior most doctor in the ward. Okay, right. Now this scoring system gives you 3 things: the degree of critical illness, how frequently you are supposed to monitor, and thirdly, where should you look after this patient. Now this patient can be looked up in the ward, 4-hourly monitoring, 2-3 nurses in the ward, 4-hourly monitoring is not too bad though, they can manage 4 to 6 hours, and they call the junior doctor and tell, okay, there's a patient who has a score of 1. Okay, right. The doctor has to attend within 30 minutes. That's what it says internationally. And the doctor should give a plan of management. And that plan is going to be implemented the next 4 hours. And if the patient is deteriorating, the score is going to go down from 1 to 5. Agreed? Very simple. The score system is very simple. Then the nurse should know if the score is increasing every hourly monitoring. Can she monitor in the ward every hourly? No, she should shift this patient to the ward HDU. Okay? Or at least where the nurse's day is near. Right. Now, the junior doctor is again informed, and the junior doctor's work plan is not going well. So, the junior doctor has to get the specialist registrar involved and get the patient to be seen and change the plan of management. Okay? If the plan of management is changed, will the patient improve? Might. Yes. Now, say the junior doctor gave a drip, started a little bit of oxygen, and was monitoring, probably given some antibiotics. But the patient has a bad wound. Now, the specialist registrar is coming. The patient is becoming septic, so the specialist registrar came. BP is a little low, and the patient is not breathing effectively, respiratory rate has gone up to 30, so the specialist registrar can do a little bit more. Okay, fluid boluses, probably a CV line, and get the volume right, put the catheter and see whether the patient's urine output has come up. And probably the patient may need a wound toilet. Don't you think so? The specialist registrar can do a little bit more than that and improve the quality of care in these patients, right? Then the third one, right, if the patient is not improving, then again the score is dropping. But if the patient is improving, you're done. You're okay. The patient can be moved back to the ward. Okay, patient has improved. Now, if the patient's score has gone down to 6, now 6 or more, then the senior registrar has to inform the consultant, and the consultant should know that this patient is not doing well. Probably the patient may need amputation in the theatre. So the theatre should be booked, blood should be cross-matched, patient should be optimized, anesthesia should be informed, right? So that kind of management is very important here, where the patient needs further escalating the management. Okay, but if this patient is okay, so and also if the patient's blood pressure with fluids is not picking up, patient might need ICU care. So whom do you want to call? Probably the intensive care consultant or the ICU consultant, and ask for a bed, book a bed. Probably after the surgery, patient might not go to the ward but to the ICU for inotropes or vasopressors or even CRRT, right? So that is why this at this point the patient's monitoring should be more aggressive. Half hour, quarter hourly, so that can't be done in the ward ICU. But if the ICU bed is not available, you can book an ICU bed. The moment the ICU bed is available, they will call you and take the patient in. Until then, you have to look after the patient at this level with inotropes, probably with a CV line and half hour monitoring or quarter hourly monitoring, and looking after the patient may improve the patient or may not deteriorate, or you can even intubate the patient sometimes, and when the ICU bed is there, you can send the patient to the ward. So will the patient arrest? No. Before arrest, we have intubated. Before arrest, we have got the pressures right. Before arrest, we have started the management. So there is less likely a chance of patients arresting and going into cardiac very poor prognosis. Now, if a patient arrests, the prognosis is poorer than a patient being picked up and intubated and sent to the ward. Those patients have more chance of survival than an arrested patient going to the ICU. So again, I'm reminding you, our resources are poor. If you send the patient to the ICU, that patient should have a reversible condition where the patient should recover and go home. Otherwise, the patient will get all our resources and die in the ICU on a ventilator. Will that be all right? No, nowadays we can't afford to do that, right? Okay. Anybody sleepy can stand up and sit down. Okay? Right. Now, you may ask me one question. Sepsis. We were talked about something else. Now, sepsis is a major condition in our setup, not only our setup, internationally. It's creeping up, and the more we get with the years to come, sepsis is advancing and increasing, and it is one of the major disease conditions which costs a lot per patient. Okay, so now those days we were talking about something called HELP and QSOFA. Can you remember? This was a tool which we looked at to pick up septic patients. Very simple. Three things: blood pressure, mental state, and respiratory rate. Now, these three are also included in the early warning score. Remember that. We have 6 parameters, out of them 3. Now, this has been actually taken out because this is not a very good tool to pick up sepsis even. Now, the latest sepsis 2022 guidelines says don't go by only QSOFA. Early warning score is better. You can do both, but this may not be the best to pick up patients. Okay? So now we are not talking about this. Early warning score is better. Right. Now, when you have a patient who is deteriorating, you are going to take bloods. Now, the bloods are important for you to further assess the patient in SOFA, not the quick SOFA, but the SOFA, sepsis related organ failure assessment score. So you take bloods to assess the respiration, coagulation, liver issues, cardiovascular, central nervous system, and renal. Why do you want to assess this? By the time you take the patient's bloods and send and bring it, you know which organs are failing. And you can label the patient, okay, this patient is having multi-organ failure, 1, 2, 3, these 3 organs are failing. ICU, please look after these 3 organs. That's how it goes. So the moment you pick up a patient who is deteriorating, you send the blood. And the blood investigations involve ABG, where your respiration is assessed, coagulation, platelet count, and the INR statistics. Liver functions are assessed with the liver profile. And if the patient is supported with inotropes, dopamine is no more there. These 2 drugs are the ones that we use in cardiovascular, gaining cardiovascular stability in sepsis. So if those drugs are there, we know that the patient is cardiovascularly unstable. Central nervous system, we can go for APUV or GCS, and we can assess that. Renal, we assess the renal profile with urine output, and we know the renal functions are good or bad, right? So at the end of the day, we can call it which organs are failing, and when the patient goes to the ICU with the scoring system score over 6, the ICU people know which ones to support, which ones to look after very carefully. Okay, right. Now let's get on to this. Now, can you see the purple, red, yellow colors? Now these colors are there for the nurses to be have a cushy life, I would say, right? Okay, because this purple is said to be calling the medical emergency team. Red is to be calling the multidisciplinary team. So medical emergency team is called when there is a cardiac arrest, threatened airway, the patient is bleeding, any uncontrolled seizure, anything very urgent, about to die patients. This multidisciplinary team is called when the patient is unstable, like chest pain, unrelieved, urine output going down, pressures are not holding, needing inotropes, right? And the yellow one is where the patient is not doing well with saturation or one of the systems where out of the 6 parameters, 1 or 2 parameters are going down. Now I'm back to this chart again. Can you see the colors now? Can you see the colors? Now these colors are there for the nurses to inform the relevant team. Okay, so it's very easy. If you chart on this, they know which team to be informed, right? Okay, so I'll skip this slide. So let's get on to this. A 64-year-old man, past medical history, hypertension, arthritis, on ramipril and ibuprofen, heavy smoker, alcoholic. He has a 3 days history of abdominal pain with fever, chills and rigors, and he has slight difficulty in breathing, right lower chest pain. Is alert, uh, but temperature is very high, blood pressure has dropped, heart rate is high, and respiratory rate is high, and he has not passed urine for 24 hours. Severe abdominal pain. What do you think? What is the immediate action plan? Quick, tell me. I don't have the time, so I think I have to. Okay, we are going to go on ABCD approach. Okay, so we are going to give high flow humidified oxygen 4 to 6 liters. Why? Because he is conscious, but his saturation has now checked. We checked and it's 92. We have put a cannula and we are giving saline. We have put the catheter because he has not passed urine for 24 hours. We have started monitoring. We have taken the investigations because we want to know the SOFA score, right? And what is the score now? Can we assess in 5 minutes? I think we can do this. Talk to him, get the pressures, everything. In 5 minutes, you would know the parameters, right? Now, these are the parameters that have got deranged. Okay, saturation low, blood pressure low, pulse rate high. Right now, the score is 14. You can calculate. Is it he critically ill? Yes, he is critically ill. So what can we do now? Okay, we are going to go on ABCD approach, right? So now we know if they are unconscious, they are going to have these problems, tongue falling back and all that. But you can, if they have airway obstruction, these can be the situations where you get airway obstruction. But this patient doesn't have that, does he? He's alert talking, right? Only thing is, so if you have a recognized airway obstruction, you know what to do, right? These are the signs and symptoms that you might have in that patient if the patient is having airway obstruction. But if he is not having airway obstruction, you can just put a mask and high flow oxygen and go to the next step. But if the patient is having airway obstruction, another patient who has, you have to do the triple maneuver, suck out secretions, go for an advanced technique of airway management, and probably you may have to go for high flow oxygen through a ventilator or an ambu bag, right? Now, breathing problems. They can have 3 types of breathing problems. What are the 3 types? Drive is gone. CNS depression, if they have got tongue falling back and the carbon dioxide levels have gone up, carbon dioxide narcosis, they will have a slow breathing rate. Efforts have gone down if they have any other issues. Now can be in trouble with all these conditions. So if there's a breathing problem, again, you can check whether the patient's breathing efforts are good, look, listen, feel, and if the respiratory rate is not good, auscultation in the chest has added sounds, trachea is deviated, or if there's displacement, efforts of breathing are poor or gasping, saturation is poor, you have to go for a definitive airway where you are going to go for non-invasive or an invasive airway, right? So, if the patient's unconscious, definitely the patient is going to have an invasive airway, otherwise the patient can go on a bag mask ventilation, right? Eliminate or a normal mask. So you have to think about treating the underlying cause. Now the next step is circulatory problems. This can be hypovolemia, cardiogenic, obstructive, distributive, and other causes. I'm not going to go into details because I'm sure you know all these causes. So they come out with these kind of symptoms and signs: shortness of breath, syncope, and capillary refill low, and pulse. Capillary refill time is prolonged. Pulse, blood pressure, organ perfusion is going to be low, and the mental state, oliguria, is going to come up. Bleeding, if they are bleeding and having fluid losses, they also will have a cardiovascular recurrence. So what should we do? We know that the patient is needing IV access, rapid fluid challenges, and if the patient is septic, the patient needs a blood culture, antibiotic, and then fluid challenges. Right. I'm going to go quick because I have only 2 more minutes now. Right. So how are we going to do the disability, APVU, and if the patient is unconscious, definitive way, and you have to go, look after the hypoglycemia, hypothermia, and the secondary brain damage issues. So, exposure, you expose the patient with maintaining dignity of the patient and also avoiding heat loss, and also you have to check the patients if there are injuries or if there are any other issues, surface, orifice, extremities, cavities, and veins, we have to check. And right, now let's get back to our patient. Our patient is not doing well. They wanted the CT contrast scan, contrast CT scan, and it has been done, and there is bowel perforation. Okay, urine output is now 15, 20, 25 ml for last 3 hours. The saturation is 92 with 6 liters oxygen. Now what shall we do? Is this patient is in trouble with the renal functions? Yes, this patient is a high risk patient for AKI. Why? He was a hypertensive patient. He was on ramipril, right? Okay, and he's on NSAIDs. He's hypovolemic, isn't it? Right, because he's septic, bowel perforation, hypotension, and now we have given him contrast. Okay, kidney is in bad shape. Okay, yeah, the kidney is really in bad shape. Right, age of the patient is also not too good. Right, now this is the kind of a kidney we are now having. Good kidney is now going down. Right, okay, now we are at this stage, damaging. Now these are the other investigations we have got, and you can see the urea level is 16 and creatinine has gone up. So we are now having, and also the potassium is creeping up. Now we are heading for AKI. Now what is AKI? Acute kidney injury. Now this is the tool for us to pick up AKI. Now it says two things. One is how to look at the urine output. If it is 0.5 ml per kg per hour for the last 12 hours, earlier actually now they have changed this to 0.3 ml actually, right? For last 12 hours, and the creatinine level is creeping up from the normal to 1.5 times. Okay, this patient is in stage 1. Okay, right. Now, if that has gone even beyond 12 hours and the baseline has creeped up to 2 to 3 with the serum creatinine levels, stage 2. Stage 3 is above 3 times creatinine levels and no urine output or 0.3 ml or less for 24 hours. Now, what shall we do here? When you have a patient with stage 1, you have to fill him up. Food for the kidney is volume, the amount of fluid and the pressure. Otherwise, the kidney is not going to give an output, isn't it? So, what should you do here? You have to put a CV line, give the patient fluid, goal directed, and get the CVP around 10 to 12. Okay, now we have got the volume right. And if the patient's pressure is not right, because sometimes they can have severe vasodilatation, we have to get a vasopressor to pick the pressures up. Now, if you do these two things, can we get an output? Probably we can if we are on time. But sometimes we may not be able to do so if the kidney is going on acute tubular necrosis. Then we have to augment the kidney with a bit of furosemide, and we have to get the nephrology input. Okay, so here we augment the kidney and try to get the output, but failing which we have, where the patient goes into stage 3, we have to offer them renal replacement therapy for a short while to rest the kidney. If the kidney is rested, it will pick up again and it will work further, right? Okay, so Surviving Sepsis campaign also has given the same things. First hour to do certain things, antibiotics, fluids, and they have asked us to avoid starch, but to give all these and start antibiotics in timely and resuscitate the patient with these goals. CVP, mean arterial pressure, now they say don't go for the 65 mean arterial pressure because some patients, their pressures are low, so you might even target a little less blood pressure. Urine output and normalizing the lactate levels. If the lactate levels are above 2, you have to resuscitate. When you are resuscitating the patient and the output is coming up, the lactate levels will slowly go down. So that is about how to pick up a deteriorating patient and manage a deteriorating patient. Okay, so summarizing my lecture, early recognition is very important in a deteriorating patient. Warning symptoms and signs are given before cardiac arrest, so pick it up early and act upon that. Airway breathing circulation problems can cause cardiac arrest. ABCD approach is the most relevant and important way of managing these patients. Prevent AKI by timely intervention.